Hello, my name is Dr. Bonnie Key, and I'm the editor-in-chief of JACC CardioOncology and the founder's associate professor of cardio-oncology at the Perelman School of Medicine at the University of Pennsylvania. Today, I have the pleasure of being joined by Dr. Ninian Lang. He's an associate professor at the University of Glasgow, Institute of Cardiovascular Medical Sciences. He is also an honorary consultant cardiologist of the NHS in Greater Glasgow in Clyde, Scotland. He's the senior author of a state-of-the-art review published in our March 2022 issue of JACC CardioOncology, entitled Mechanistic and Clinical Overview of Cardiovascular Toxicity of BRAF and MEK inhibitors. Ninian, thank you so much for joining me today, and thank you for your excellent contribution to JACC CardioOncology.
Oh, well, thanks very much for having me. I'm delighted to be here.
Great, great. I wanted to present to our community some key points from your paper. So if you could tell all of us, in your view, what are the three most important take-home messages for our readers to learn as they review your excellent piece?
Well, thanks. Yeah, I think the main message I'd like to get out there is that cardiovascular adverse effects from these drugs, BRAF and MEK inhibitors, are actually very common. They may not have been quite so much on the radar as some of the other drugs, but I think that's going to change as we go forward. So I hope that this is a timely piece. So the main adverse effects from these drugs are systemic hypertension, the most common, followed by left ventricular dysfunction, which may or may not be an isolated phenomenon, but probably more of a double hit effect from hypertension than direct cardiac effects. Venous and arterial thromboembolism does occur, probably less frequently, and there are some effects on the electrocardiographic QT interval. I think the second thing to say, and that we've tried to highlight in the paper, is that in common with most cancer drugs, these were initially administered to patients with advanced cancer disease, but now are being administered to patients with much, much earlier stages, particularly in melanoma, and can be used in the adjuvant setting. So where survival, over 5 years is 70 to 80%. So the relevance of cardiovascular adverse effects is really, really much more important to those patients, both in the short, medium, but also probably in the longer term. But we don't really have great data to the longer term yet, but that will be coming. And the third thing I'd like to point out, really, again, as is common with a lot of targeted therapy, I think the profile of the cardiovascular adverse effects really just speaks to how common the overlap between important cardiovascular physiologic pathways and the overlap with cancer pathology and the therapeutic targets, how much that overlaps, and actually how, with retrospect, a lot of these adverse effects might be more predictable than we might have thought right at the outset of drug development. And I think that's how the field is evolving, is really to try and work better together to think at earlier stages about what the collateral damage may well be from these.
Ninian, excellent point. So just to reiterate and emphasize again, that overlap between the common mechanisms between cancer and cardiovascular disease, and how we can leverage that understanding to really advance our field and predict toxicities earlier. Certainly the growing relevance, because our cancer patients and survivors are living longer, secondary to these excellent therapies. And of course, the adverse cardiotoxicities of these therapies, hypertension, LV dysfunction, VTE, and increased QT prolongation. Tell us about hypertension and blood pressure control. What are your optimal targets, the evidence behind that? And then which antihypertensive therapies do you usually turn to first?
Sure, yeah, so it's a difficult field. I don't think anyone would deny that we have, no one would claim that we have great evidence to support what we do here, but this is an area that I've been actively engaged with, and we've really tried to think about blood pressure targets before therapy as an opportunity for screening, during therapy, and then in the long-term survivor setting, and in particular, drugs that we know that are going to be associated with a rise in blood pressure. And the archetypal drugs there, of course, were VEGF inhibitors, angiogenesis inhibitors. So these sort of suggestions have evolved from there. But in the pre-treatment group, we see this as an opportunity, particularly because there are so many patients with cancer who have hypertension as a comorbidity. If in the oncology clinic the blood pressure is less than 130/80 and is measured properly, I think we can be reasonably comfortable to proceed. Patients who have blood pressures above that, in the absence of pre-existing cardiovascular disease, CKD, then we may be more comfortable with a threshold of 140/90. But I think this is still an opportunity to optimize therapies. But at the same time, what we don't want is a big delay to absolutely nail the blood pressure, because at this stage, getting on with cancer therapy really has to be the key. So people with pre-existing cardiovascular disease, CKD, we really do want the blood pressure less than 130/80 before starting, but the rest, probably we can be a bit more lenient, and that process can go hand in hand while actually getting onto the BRAF and the MEK inhibitor. Then we moved on to the during treatment phase, and we're a little bit more relaxed, I think, during that in terms of the thresholds. And as long as the blood pressure is consistently below 140/90, so moving away from the 130/80, if it's below 140/90, I think we're happy, we're comfortable. The window of up to 160 millimeters of mercury systolic over 100 diastolic, that's an indication to continue the BRAF and MEK inhibitor, but really to optimize blood pressure treatment at the same time. When you get above those 160/100 targets, then really I think we would recommend that the MEK inhibitor is withheld until the blood pressure is brought back beneath 140/90. And then when that's achieved, and hopefully that can be achieved, then the MEK inhibitor can be reintroduced at a lower dose, and things taken from there. In the post-treatment group, the long-term survivors, we've come back again to being a bit more strict, thinking about a 130/80 threshold for all comers, actually. And the rationale for that is that patients have been exposed to agents which would be expected to have cardiovascular adverse effects. And you might extrapolate this, although I appreciate not in the presence of great evidence, you might extrapolate that to suggest that those effects were similar to having a longer history of pre-existing cardiovascular disease, for example, which is why we're a bit more strict. But I think there's a big amount of work that needs to be done to really understand what the thresholds should be, and to avoid issues with polypharmacy, intercurrent infection, hypovolemia, et cetera, these things that patients suffer during treatment for their cancer. You asked also, though, about what agents I would typically turn to. I think in the preemptive phase, there's a lot of optimizing the current therapies that patients are on, whether that's calcium channel blockers, avoiding verapamil and diltiazem, but would optimize those. But if we were starting something new, and particularly during therapy, my favorite choice would be an ACE inhibitor or potentially an angiotensin receptor antagonist. Really, again, to try and effectively control the blood pressure, but with the hope that that may have ancillary effects in preventing or reducing the likelihood of associated left ventricular dysfunction, or even potentially renal end organ effects. So ACE, ARB would be my top line, and otherwise it's standard therapies, but avoiding verapamil and diltiazem because of the drug interactions.
Yeah, thanks so much for those excellent pearls. So certainly a great need for additional evidence, but these are really based upon your experience and your best practices. Some nice pearls there in terms of use of neurohormonal therapies, also your approach in terms of prior to, during, and after cancer therapy, cardiotoxicity. I certainly think as a field and as cardiologists, aggressive blood pressure control is critically important, but not to delay therapy. That's another key point, because these really can be life-saving cancer therapies. Another question about your best practices as it relates to LV dysfunction. Tell me a little bit about that in terms of your approach here.
Sure. So I think a lot of this is about ensuring the correct diagnosis in the first place and getting some balance. What we recommend is that all patients starting these drugs receive a baseline echocardiogram, and I think that the value of that, and ideally with a global longitudinal strain assessment is so important, because without that, you don't really know what the starting point is. And then repeat an echo after 4 weeks, and then 3 monthly thereafter. But in patients who you think have a genuine left ventricular dysfunction in the context of these drugs, and by that I would mean a drop in left ventricular ejection fraction of greater than 10% to a final value of less than 50%, then I think you're into another, as it were, branch on your flow chart. And the critical distinction there is to decide whether or not this is asymptomatic left ventricular dysfunction, or whether the patient has good going symptomatic heart failure. And the two of them are actually quite distinct. Patient who develops heart failure, in some ways, in terms of a management strategy, is somehow more straightforward, in that you treat that patient aggressively with standard heart failure medicines, the 4 pillars as usual, and it's unlikely that you would want to restart or be able to restart BRAF and MEK inhibitor. Patients with asymptomatic left ventricular dysfunction, the evidence there suggests that there may be reversibility with temporarily holding the MEK inhibitor. It's reasonable to continue the BRAF inhibitor and to repeat imaging at 4 weeks and see where things are at that point. We would have a very low threshold for introducing beta blocker and ACE inhibitor in that context. If on your reassessment the left ventricular function comes up above the institutional lower limit of normal, or 50%, then it's reasonable to restart the MEK inhibitor at a lower dose at that point and continue on from there. The use of biomarkers is not well established here, but I think it's a really, really important field for the future. I think, understanding what incremental information they give us in terms of prognosis, likelihood of recovery, likelihood of progression to heart failure and irreversible toxicity is really important. And also particularly important in making that initial distinction about asymptomatic left ventricular dysfunction versus heart failure, because we all know that these patients have other reasons for fatigue, breathlessness, and ankle swelling, and we use natriuretic peptides in particular to try and help guide whether or not these are truly cardiovascular symptoms. And again, I think the final point I would make is that it's all well and good making a nice flow chart, but actually these patients are all heterogeneous, and these decisions have to be made really in the context of alternative treatment options, but also the stage and grade of the cancer. And we can't do any of this without having close interaction with the oncologists, and also chatting carefully with the patient in front of us in the clinic. So I think that really is probably the most important thing, is this understanding of stage and alternative treatment options.
Again, excellent, Pearls. Thank you so much. Just emphasizing that need for multidisciplinary collaboration with the oncologist and including the patient in all of these decisions, key points, and really aggressive use of neurohormonal therapy. And it's the change over time in many of these biomarkers and even echo imaging measures, such as strain, that are important and associated with adverse cardiovascular outcomes. Just in closing, what do you think are the greatest knowledge gaps here, and where does the field really need to go? What type of science?
Yeah, it's an important question, and I think you could extend this to most areas of cardio-oncology, but I think BRAF and MEK inhibitors are a little bit lagging behind in terms of our understanding. I think we need to better understand who is at greatest risk from these toxicities. So the European Society of Cardiology have endorsed some baseline risk assessments for a variety of different cancer therapies. But whilst that's a laudable effort, I think we don't have great evidence to understand really the weight that those risk factors actually mean in terms of longer term outcomes. We can take some data from clinical trials, but we don't really understand whether or not those patients are representative of the real world. We don't understand whether the definitions are collected in the way that we would recognize as cardio-oncologists. So I think what we need to do is really characterize in a detailed, robust way the longitudinal effects of these drugs in those sorts of patients that we see in our day-to-day practice. And with that, we can start to understand who is at risk, and also to understand the role of biomarkers, longitudinal changes in biomarkers, and to do a deeper phenotype and to really understand what the mechanism behind these effects is. Are we seeing effects that are primarily hypertension related? Is there a direct cardiac toxicity effect, perhaps interactions with angiogenesis? And by understanding that, we can then think about what might be the best ways of preventing or treating these cardiovascular adverse effects. We're very quick to say that angiotensin converting enzyme inhibitors or beta blockers should be a good way of preventing or treating these effects. But actually, those drugs are used for patients with heart failure and neurohormonal activation. I think we need to get back to understanding the mechanism, to understanding whether there are specific direct vascular and cardiac pathways that can be much better and directly targeted, really thinking about the mechanism of the toxic effects of these drugs. So we're working actively and hard in these areas, and hopefully with the rest of the community, we'll make some advances.
Great. Well, thank you so much. We certainly look forward to your important contributions to the field. And Ninian, thank you so much for joining me today, and again, for your excellent state of the review.
Thanks very much. Thanks for having me.